So welcome to this series called The Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk. Welcome to Top Med Talk. I'm Monty Mythen. I'm delighted to be talking to Dr. Paul Wischmeyer, who's a professor from the Department of Anesthesiology at Duke University Medical Center in the United States of America in North Carolina. So, Paul, welcome. How are you today?
I'm great, thank you. Thanks for having me.
Tell us a little bit more about your role at Duke, particularly related to nutrition.
Sure. So, as you mentioned, I serve as a professor of anesthesiology and surgery at Duke, but a big part of my job is the director of nutrition therapy and nutrition service for Duke Hospital. And that involves a number of roles, including starting a perioperative enhancement team of POQI nutrition clinic to see patients and attempt to optimize them before and after surgery.
Paul, we touched on this in a previous podcast. This is, internationally, but even in the USA, this is quite unusual, isn't it? And I think that in a previous podcast we discussed the fact the institution's been convinced that this is value for money. This is a quality initiative, which is the right thing to do, but also makes financial sense.
Absolutely. It, to my knowledge, may be the only institution that's making this commitment, at least in the United States, to nutrition as an essential part of patient care, not only because it's clinically the right thing to do, but because we've also created a real business model around the care of patients and the improved outcome of patients, both in the preoperative and postoperative settings.
So back to this paper, which is another one in the POQI series, the Perioperative Quality Initiative. So this is the second series of papers. Paul, tell us a little bit about the process to lead to these consensus statements.
Sure. So the POQI process, or the Perioperative Quality Initiative, creates consensus statements, as you mentioned, where we bring experts in the perioperative world that could include surgeons, anesthesiologists, in this case dietitians, and other perioperative interested individuals to comment and review the literature and provide expert consensus guidelines around different topics. In this case, nutrition and the role of nutrition screening and nutrition therapy for patients having major surgery.
And in the paper, Paul, there are in total 12 recommendations that are graded as well. So it's an evidence-based process, but there's also quite a lot of opinion in there as well. We don't have time to go through all 12, but I think we'll pick them up if we go through the figures and infographics. So beautiful infographic, figure number 1. I think you've won the prize so far for the best infographic in the POQI series. I don't know who you got to help you, but well done for that. So can you just walk us through that one? Because it's some pretty startling statistics in there.
Absolutely. I think that one baseline piece that all caregivers should know is that 1 out of every 3 patients admitted to the hospital anywhere in the world on any service is malnourished. And when it comes to the major GI surgery patients we care for, that number goes up to 2 out of every 3 being malnourished, which is really a stunning statistic. And that creates real risk for patients. They have a 3 times greater risk of complications and a 5 times greater risk of mortality. In fact, malnutrition is the number 4 cause of death within 30 days of any surgery in the NSQIP data. And it's the only modifiable risk factor in the top 10.
But you say the next thing you say is that only 1 in 5 hospitals we believe currently screen for that.
Sure. We did a survey, actually a medical student and I who were passionate about this, and we surveyed the major academic medical centers in the U.S. that have GI, surgical, or oncologic fellowships, and only 1 out of 5 chairs of those fellowships reported having any form of screening process. Now, in that same survey, all the surgeons, or 75% plus of the surgeons, felt like periop nutrition delivery would reduce complications, and it was a big problem. but no one was looking for the patients. And then that's unfortunate because, for instance, for every dollar we spend on nutrition therapy in the hospital, we could save $52 in hospital costs, and this comes from large multi-million patient database data that we've published in the past. And so still only about 20% of our malnourished surgical patients are receiving any nutrition therapy at all.
So why... It's very hard to understand that, isn't it? We went through this at the time. If the return on investment is so great, is that just because in life we find it hard to believe that lunch, dinner, our eating habits are really going to make that much difference to our long-term survival? Is this just a reflection of overall the sort of terrible snack habits we have in hospital? Personally, as physicians,
I think some of it is that, and I think some of it's true lack of education. I can tell you over 75% of all U.S. medical schools do not have a required nutrition class.
Wow.
And when you survey new registrar or resident doctors coming out of training, less than 15% report they feel prepared in any way to discuss nutrition issues with their patients. Okay. And so it's just not something we're taught.
Yeah. And what about leading by example? Because I don't know, well, I do know what it's like at Duke, but in the NHS, you turn up for a meeting, it's going to be coffee and donuts, or it's not going to be fruit snacks and smoothies or whatever it is. Are we not leading by example as part of it as well?
I think we're not. I think, it's much easier for our patients to feel motivated to pay attention to nutrition when it's part of what we pay attention to and we make it part of our lives. And so I think it's essential for all of us to role model that for our patients and to really understand what it takes to get the protein in we need to recover and to be able to express how to do that to our patients.
So the next figure is figure 2, which is described as the POQI Nutrition 6. Can you skip us through that quickly?
Sure. I think we wanted to make this simple. With the lack of basic nutrition education out there, we wanted people to have some simple takeaways. And I think the first is clearly that screening patients for malnutrition is essential. And we'll get to a figure later where we try to make that simple for people. I think the next piece that is simple to take away is protein. Protein is more important than calories, we believe, to recover the lean body mass losses and heal as patients need to do after surgery. I think the next one clearly is, I use this analogy to my patients, having surgery is like running a marathon. And nobody would get prepared for a marathon by starving themselves the night before the morning of the marathon and or not hydrating themselves.
Yeah.
And so stopping feeding as late as possible pre-op, not at 5 p.m. the night before to where you enter the marathon of your life, dehydrated, not having eaten for 18 hours or longer, I think is a big change, at least in U.S. practice. And so these fluid carbohydrate loads can be quite important. And then equally as important, starting feeding in the recovery room.
Yeah.
So again, you've got to recover from the marathon. And we know early feeding has got significant reductions in mortality when the data is analyzed.
And just to be clear, because some people, including clinicians listening who are trained a very different way, it's in enhanced recovery, and generally speaking now, it's completely normal to be letting people drink soon after waking up from major surgery and general anesthesia, and to be tucking into some food shortly after that.
Yeah, and I think you, with the early enhanced recovery projects we've done and led, have really changed the world's view on, A, this is possible, and then B, this is improved outcome in the patient. So I think the work you have done in England and others have done in the enhanced recovery world has really changed that this can happen.
And it was right there from the early publications about enhanced recovery, about a quarter of the program from Professor Kellett's perspective was get them drinking, get them eating, get them mobilizing, get those patients living the dream. So can you take us to figure 3, Paul, which is another big paradigm step, is this suggestion that we ought to be screening patients in a more structured fashion. Now, hand on heart, I do not believe we've been doing this well or effectively in any healthcare system I've worked in, but it looks completely sensible to me that this should be a standard of care, and what you're proposing there looks very achievable.
Yes, we created a screening pathway with very simple questions that are drawn from other literature, data-validated screening questions for malnutrition, and we targeted them at surgical patients. And so the questions are simple. Is your BMI low? Is it less than 18.5, or if you're older, less than 20? This is your metabolic reserve for surgery and illness. If that's low, we need to pay attention to that. Has the patient lost weight, or has your patient lost weight, say 10 pounds in the last 6 months, or say 5% of their body weight in the last month? So simple question around weight loss. And then have the patients been eating less than half of what they would normally eat? So again, an acute malnutrition state. Again, you wouldn't want to run a marathon not having eaten for a few days before you got on the race course. And when this surgery is the marathon of a patient's life, why not have them go in the best prepared they could be? And these simple questions we found are very highly predictive of complications in patients having surgeries. And then an albumin less than 3, although not a perfect nutrition marker, highly predictive of complications in major surgery.
Now, Paul, some people get a bit, I don't know why, but some people get a bit stressed about the need to measure the albumin. I mean, that's readily available on the panels we do, isn't it? That's not a heavy lift.
It is.
Yeah. So the next...
And there's as well.
I'll loop back on something about using some of the imaging that's available in a second, but if you could go forward to the what to do about it. So in the next figure, which is figure number 4, another prize-winning example from you there, you've got the low nutrition risk and the high nutrition risk, and there you put it down for us as in a simple diagram what you think we should do about it. Talk us through the low risk for a sec.
Sure. I think this is where a lot of people have been challenged. They said, I think I'm able to ask these questions, but then what do I do?
Yeah.
And I think first you discriminate. I think every patient can benefit from the week before surgery taking in an oral immunonutrition supplement or high-protein nutrition supplement. We have over 3,000 patients worth of data in 30 trials showing we can reduce infection as much as 40%. From even a well-nourished patient, say, like you and I'd like to believe we're fairly well-nourished, we would benefit, our family members would benefit. I would never let my mother have surgery without taking an oral immunonutrition supplement for the 5 to 7 days before surgery. In fact, I've had her do it before.
And these are drinks that are readily available. This is not rocket science. This is okay. But, I mean, it's important
ready
science.
Ready online.
Yeah. But easily accessible.
We understand the science of it.
Yeah.
Yep.
So the high-risk patients, what's the gearing up there? Is it the complexity then of the nutritional intervention, or is it the duration, the magnitude?
I think it's the duration in many ways. We really would like 4 weeks with these patients to really begin to replete them, to re-nourish them. And then we would like to be able to give 3 to 4 weeks of a high-protein oral nutrition supplement or enteral or parenteral nutrition if they cannot tolerate oral nutrition, as some of our, especially GI cancer patients, can't. And we follow them weekly in this case for compliance. We have a physician assistant or a dietitian call them and ensure they're able to drink the supplement, able to get the supplements. We write prescriptions. We give samples, because in the U.S. with a prescription, they can get healthcare reimbursement for these. And then we check them before they come back. And then the same people follow them in the hospitals, and we treat them for a month after. It's the same supplements.
And your overall evaluation of this is highly cost-effective. So any pushback about this is unaffordable. It shouldn't be unaffordable in the USA, but unaffordable in other healthcare systems. As far as the group's concerned, this makes sense. This stacks up financially as well as being cost-effective, i.e. good for the patients.
Absolutely. The readmission rates and infection rates and complications that patients have that are malnourished are truly tremendous. And we have data going back many years for the benefits of not just nutrition, but other nutrition interventions, reducing complication rates, infections 2.5-fold, in fact, if you take a gastric cancer population who's malnourished and treated versus not treated.
Brilliant. So Paul, I just want to put up one thing towards the end. In table number 2, I think we've covered off in the infographics most of the recommendations, but I know that some people will jar before they've looked at the detail of this about recommendation number 4, which is to evaluate lean body mass via a CT scan. Now, I know there's a twist to that tale, which makes it achievable and affordable. So could you just expand on that?
Sure. The evolving technology is allowing us to use the routine CT scans we get to evaluate our major GI surgery patients and other surgery patients. And a program can calculate, actually, the lean body mass quality and quantity of the patient. And we actually can, now I'm discovering, do this even on our basic radiology programs that exist on our Epic workstations in the U.S. and probably in other electronic medical records around the world, just by tracing out the lean body mass portions of the L3 cut.
Okay.
So there are many publications now around this.
So the patient is, just to repackage that, the patient's getting the CT scan anyway. That's part of the workup for the procedure.
Yes.
So the information, we're sitting on the information and not necessarily utilising it. And the L3 cut is the third lumbar vertebra. You take a slice through there, a computer slice through there, and you can then look at measures of lean body mass and perhaps even automate and turn around and say this person is malnourished, putting it crudely.
Absolutely. It's really a highly accurate measure of sarcopenia, and there are many publications in many different surgical subspecialties showing significant risk for complication in sarcopenic patients. So we've published some recent literature on this as well.
Great
We're
stuff.
reviewing all the publications.
Well, that's clear. Thank you very much indeed, Paul. Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.